came across the IAOMT and found the underpinnings of an integrated philosophy. In 2007, he opened Canada's first researched and published eco-friendly dental office, a topic on which he lectured to this esteemed academy in 2008. In 2011, he was asked to serve as the Canadian Dental Association's media expert in eco-friendly dentistry, nutrition, and wellness. In 2013, he was one of the first dentists in Canada to place all-ceramic implants, and since then he's developed one of the largest all-ceramic dental implant practices in his country. His office is one of a handful of offices in Canada limited to comprehensive adult dentistry, focusing on nutrition and metal-free options, full range of soft and hard tissue regeneration, including concentrated growth factors and neuromuscular full mouth rehabilitation. He has just returned from Austria and Switzerland, where he completed a learning exchange at the world-famous integrated health clinic in Paracelsus, resulting in being offered an opportunity to be a dental advisor to the Paracelsus. He is honored to be back home among his biological dental colleagues from this esteemed academy and from the IABD.
The second lecture then is, not an introduction anymore, right, to the system, but it's the everyday how-to stuff, right? How to do this clinically, restoratively, surgical and prosthetics, not nuts and bolts, all the stuff we love. Now, just before we start, kind of a raise of hands, how many here are restorative implant dentists only, just restorative? No surgery, just restorative, okay? And how many are, so the rest are, how many are doing surgical? Okay, and how many have experience with any zirconia implant? Surgically. Okay, and how many of you have experience with Ceraroot? Okay, cool. All right, cool. So, by way of, again, disclaimer, I do not have any financial interest of a product in my talk or with any companies offering grant monies for this continuing dental and medical education program. So again, I have no financial ties to Ceraroot. So let's look at the outline of this lecture. So there are soft and hard prerequisites to placing Ceraroot implants. By soft prerequisites, I mean, it'd be great if you had these prerequisites, and if you don't have them, it's okay too. But hard prerequisites are prerequisites, things I think you really have to have if you're going to do Ceraroot implants. We're going to look at some basic bread and butter cases. Remember, like I said just in the last lecture, that this implant is not a niche implant. It's a basic bread and butter implant. So we'll look at the basic cases. We'll look at some moderate cases. We'll look at some advanced cases, and some of the lessons I've learned along the way that I want to share with you so that you don't need to learn those lessons yourself. So we'll talk about mentorship a little bit as well. So some soft prerequisites. Okay, atraumatic extraction. This is a separate course, of course. There are many courses on atraumatic extraction. But essentially, we want to be able to remove a tooth without raising a flap. We want to be able to do a sulcular or an internal flap. The idea is to keep the periosteum attached to the extraction socket, so there's no blackout, right? There's no immunity blackout. When we raise a flap, when we're taking the periosteum off the bone, and we stitch everything back together, there's going to be an immunity blackout period where there is not proper blood flow to that flap, and our site is exposed and in danger. So if we can help it, we really want to do atraumatic extractions. Things that we talk about in mentorship. So that minimizes the chances of healing disturbance. As a compromise, you can do an envelope flap. So sometimes to take a tooth out, right, I have to do something. If I have to do an envelope flap, I'm going to do an envelope flap as a compromise. When I raise an envelope flap, I'm already thinking in my mind, this might not be immediate. I'm having to, the roots are so curved, and the bone is just so brittle. I'm having such a tough time getting this tooth out. I have to raise an arm. I'm already thinking I might not be able to do an immediate here. C'est la vie. That's okay. But I don't know if any of you heard of Optrogate from Ivoclar. You're going to see this in many of the slides. This is a really nice tool for you to have. It's like having an extra assistant in the room because it holds the lips and cheeks out of the way so you don't have to do that. So atraumatic extraction, what we're talking about is, right, a patient of yours comes in and they have these two bombed out root canal molars here. They're just, what you want to be able to do is to remove these teeth without flaps so that you can, again, keep the blood supply intact. Another soft prerequisite is a basic socket preservation. Something, a patient management tip that I'll share with you is that when we do these, I'll say to a patient, Mr. Jones, 80% of the time we can place this implant at the same time as we take the tooth out. 20% of the time we can't. This is done at the consult. So they're aware, right, that we might not be able to place the implant at the same time. This takes the pressure off of us. We have enough pressure on us as already as enough as clinicians. It maintains confidence with the patient. And very importantly, the patient's ready for their fees, for the socket preservation. So, not uncommon, right? We remove very diseased, badly infected teeth. The area is very compromised. There is no buccal bone there. Of course, I would never place an immediate implant if I don't have any buccal bone. So, this is autologous concentrated growth factor called sticky bone. So this is sort of the next level past PRP and PRF. That's PRF. And this sticky bone is a great thing. We talk about this mentorship, and it's a great thing. What it allows us to do here is to use this PRP. There are two PRPs tucked inside on the lingual. That's the tongue. That's the PRF membrane. That's the sticky bone. And then we simply bring that PRF membrane. I use two of them, and I bring it down over and cover the sticky bone area, stitch it up, and that's basic socket preservation and kind of a bone graft because you get pretty good buccal bone here because of the properties of the cortical sticky bone that we're using. So those are some soft prerequisites. Some hard prerequisites is this. This is the Periotest M. Okay, if you're going to use this implant, you need to have a Periotest M. Periotest M is one tool that's used to test the solidity of implants. So when you place your implant, you've waited 4 months. You're like, okay, I'm ready to impress. It's in my protocol. First thing we do, tick, 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 test it. Is it solid? If it's solid, we're going ahead with the impression. If it's not solid, obviously we're not. Remember, there's no screw. You can't torque test this. There's no cover screw to remove. There's no, if it's integrated, you need to know that. You need to know with the Periotest. So that's not optional. The other thing is a diode laser. So it doesn't matter what you have, what kind of company, whatever system, but you really need a diode laser. The tissue is so friendly to this implant, and there's a CEJ that you will need to get an impression of, that you will many times need a diode laser to get an impression. This is what the surgical kit looks like. It's very simple. There are only 5 drills, right? Starter here, and this is for the molar. That's it. There are these 5 drills. That's what I like. Simplicity. There's a countersink where you'll see that in action. And then there's how you actually pick up and deliver the implant and place it into the osteotomy. So a very simple surgical kit. All of these things, and these things are just all my own preferences, things that I've added for my own sake. So the surgical kit is very, very simple, which is very good. Throughout the presentation, I've given you my post-op instructions and my prescriptions for the different things. So we're going to look at a healed site now. Look at some basic cases. A healed site is, it's not an immediate. So the tooth has been extracted, the bone is filled in. Even though it's in the posterior, I still, like Dr. Fields, I like to do a papilla preservation incision here. So not disturb the papilla, There's nothing, this is just like any other titanium thing you do, but what's different is you have a CEJ of this implant, and the CEJ of this implant should be along the CEJ of the adjacent teeth. Remember, we said it's the most prosthetically driven implant. So when you're placing this implant, my goal is when I'm placing the implant, I have a little game with myself. I'm like, how can I place this so that when I go to impress this, I can come in, you know, with one eye closed, one hand behind my back, and make it that simple for myself. So this is the buccolingual placement. Now, Dr. Fields mentioned yesterday that in his practice with the Z systems, they use, you know, smaller diameter crowns. They use buccolingually, they make their crown smaller. They do this because when you have a smaller diameter implant, you don't want to have too much tipping forces on the crown. So you make your crown smaller. This is a classic Mish teaching. I don't disagree with it at all. It's very, very good. However, when you have a large implant, when you have 8.5 millimeter of, you know, implant shoulder here, solid zirconia, you don't need to do a small crown. You don't need to. You do a proper full-size crown because that's a proper full-size structure under it. So this is a week, this is at the end of the surgery. This is the pan. These are my instructions for a healed site. This is 1 week later. And this is 3 months later, we're ready to restore. So, like I told you, this is going to be a clinical lecture, prosthetics and surgery. You're the restorative dentist. How do you want to restore this? Take your pick, right? I can see the margins pretty well nicely here. Maybe I need a little bit of diode laser here. Maybe I just do cord around here. Take your pick, whatever you like. It's very, you know, simple, however you want to do it. You don't need any parts and pieces. There's nothing complicated. Just take your pick. How do you want to do it? And there's the finished result. Again, we don't have to make a smaller, narrower tooth. We can do a full-size molar. This is 2 or 3, at least 3 years follow-up bite wing, and we're not seeing crestal bone loss. The threads are still nice and covered. This is my post-op. Sorry, this is my prescription for an immediate implant. I'm going to skip over those. They're in your notes, so I'm not going to spend any time on those. So let's look at immediate. So the healed sites, it's simple. Drill a hole, place your implant, restore it. This is where the implant shines, is in the immediate cases. So a little bit of some tips for you. Number one, you want to drill 2 millimeters deeper than the implant length. So if you're planning to place a 10 millimeter implant, you want to drill 12 millimeters. That 2 millimeters you will need for wiggle room to get your stability at your preferred height and your buccolingual, orientation. So just drill 2 millimeters deeper than your intended implant length. And then you'll use your countersink, which I'll show you plenty of these photos. You'll use your countersink to gauge, are we doing an immediate today? Is it a go or no? Not the right conditions. We're going to do a socket preservation today, and in 4 months we'll place the implant. You see all of this with your countersink, and I'm going to show you many pictures of this. So let's look at how we do it. So that, again, remember I shared with you, I thought this was a niche implant, but this is not niche dentistry. This is everyday bread and butter dentistry. Do you have any patients who break off teeth at the gum line like this? Or am I the only one? Right? So, of course, this is basic bread and butter dentistry. Patient comes in like this, very distressed. Oh, doctor, I'm so distressed, right? No problem, Mrs. Jones. We can take this tooth out for you atraumatically and place the implant. Now, this was a premolar. We know that premolars are elliptical generally. And, well, lo and behold, so is this implant. It's elliptical. So this is the premolar implant. Remember, these implants don't come with they're not like diameter implants. Get me the 5 millimeter, get me this. You say, how about, can you please pass me let's use the premolar implant here. This is a premolar. So it's elliptically shaped. It occupies most of the osteotomy, if not all. And so that's the end of that surgery. This is the buccal view. And you'll see that I'm particularly close to this tooth behind it. And there's a reason for that. The reason is that when I placed this implant some time ago, I made the mesial of this. I extended it. Maybe I placed it too distal, and so I made the mesial of this implant too far, right? There's too much mesial overhang on this implant. Well, I'm going back in some years later now, and I'm like, I can correct this. I'm going to put this implant. You can see the outline of the extraction. I'm not going to follow that. I'm going to correct it. I want everything straight. So I'm going to follow that, make a straight implant placement here, close to this, too close to this. But I know that when I go to restore this, guess what? I'm going to correct that mesial overhang. You're thinking this when you're placing your implant. This system makes you a better implant, better restorative dentist. Plain and simple. So those are my post-op instructions. So here we have 4 months later. Again, we're nice and close here, but this is how it looks when we're going to impress it. All the questions I'll take at the end. I've got a lot of material that I want to get through, but please note the number of the slide here. Yeah, I'm sorry. When the IAOMT wants you to submit your slides a month before, okay, and a month before I had only a rough draft, and it was about 6 hours long. So I had to cut a lot. So I'm just slimming this down to the bare essentials. So some of this won't be on your slides. Some of them will be. I apologize for that. So I perio tested, and that day I just decided, okay, I'm pretty good here. I'm just going to put some cord around here. You can see there's just a little bit. I mean, on the buccal and lingual we're clear anyway. There was just a little bit on the mesial and distal. So just pack some cord, take an impression. Maybe you guys can do better crown preps than this for premolar. I can't. So when I look at this, I say, that's like the best crown prep impression I've ever taken in my life. I kid my lab all the time. I say, how you like my crown preps? So obviously this is a beautiful prep. You don't want to touch it. It's very inexpensive, a triple tray. Whether you have Ceraroot, that's great. I'm still using, PVS. I love it. And so, yeah, simple crown and bridge tray, no impression copings, nothing, just simple crown and bridge triple tray. And there's our final restoration. And I've corrected the overhang here. And there's the 2-year follow-up. We're not seeing bone loss. Again, we've corrected the overhang. So, okay, here's another, bread and butter case, right? Broken tooth, fracture at the gum line. Now, I do want to mention that in this particular patient, right, you can see that she's had occlusal breakdown in other areas. This patient had a very traumatic bite, very bad occlusion. And so as holistic dentists, what does it mean to be holistic? It just means that we're getting to the root cause of the problem, right? That's one way to define it. That's an acceptable definition, right, of holistic dentistry. We're getting to the root cause of the problems, no pun intended. Well, when someone's breaking teeth left, right, and center, and all you're doing is just doing ceramic implants or titanium implants or whatever, right, there's an underlying cause that we haven't seen. So I just want to encourage you that, when you're seeing this over and over again, don't just become a great implantologist, but actually become a great holistic dentist. Look at the underlying cause and treat the underlying cause as well. So here we've extracted the tooth atraumatically, right? This is an elliptical extraction socket, a circular implant here, be it titanium, be it a 2-piece Z systems. You're going to have voids. So this is the countersink that I mentioned to you. This dictates, is it going to be immediate or not? When I first place the countersink in, I can't get it in far enough. I know that I'm not done. I haven't prepared it enough. So I need to prepare some more. So I went in, modified my osteotomy a little more, and now when I see this, and this is the key, you're going to hear me say this over and over, this gray line represents the CEJ of where you want your final implant to be. Before I place the implant, when I see this gray line in line with the papilla, then I know this is going to be a great immediate implant placement, because it's going to, from here to here, it's going to engage all that bone. I'm going to get the solidity, et cetera, et cetera. So I'll show you cases where you put this in and it sinks down, you're like, nope, that's not going to be an implant. So this is going to be an immediate implant. The gray line is in line with the papilla. This is when I digitally place the implant into the socket. And again, when I see this, I'm like, this is great. I know that tapping this one in, remember this is the only one that's a press fit implant, I'm going to be able to get this CEJ here, somewhere along here. There we go, tapped it in. There's the CEJ. So I know that this is good placement. This was a good immediate one. Now look at the lower teeth. She's in orthotics and she's going through treatment here to fix her bite. This is the x-ray right after surgery. Sorry for the ghostly image. I was having some camera problems at some point in time during this journey, and but that's how it looked a week after, and that's how it looked 4 months after when we're ready to restore. So let me ask you, how do you want to restore this? Take your pick. Do you want to use cord? I think it's a little bit too much for cord here. I probably just use a diode and just give myself a little bit of, a little bit of clearance here, and and just take a crown and bridge impression. This is the finished case here, as well as we finished her restoring her lower arch to a proper, comfortable bite position, so that she doesn't lose more teeth, hopefully. This is the post-op restorative X-ray after about 2 years in the mouth. Okay, this seems to be happening a lot, right? Broken off the gum line, right? This is not niche dentistry. This is basic bread and butter dentistry. Patient's broken this tooth off the gum line, right? There's the pre-op X-ray. There's the atraumatic extraction, no flap. Here's my countersink. What did I tell you? I said that if that gray line, if you can't even see a gray line, it's gone too far into the osteotomy, that's not going to be an immediate implant today. So, simple, right? You can tell. You know, the patient's already prepared. 20% of the time you can't do immediate. This root was too big. So, you can't do an immediate today. You don't push it, you don't do it, you don't wiggle it, you don't have failures, you don't, so, I need a two-piece. You just know that you can't do it this way. So, we do a socket preservation. This is a different way. You should have two ways of doing socket preservation. One where you don't get a venipuncture, one where you do. This is one where you don't get a venipuncture. This is 4 months later now. The socket has healed. And whenever I do socket preservation, I'm pretty comfortable. I usually don't do a flap on the reentry. I usually do the implant flapless because I saw what that implant area site looked like. I'm confident I've got good bone there. And so I did this osteotomy flapless. It's elliptical, so because my implant's going to be elliptical. I placed the implant. This is the day of surgery, right? This is the X-ray. And we'll come back to the finished crown on that a little bit later. So, bread and butter basic dentistry, right? Single teeth in the posterior. The system is engineered for implants, right? One surgery. Less wait time, the patient loves it, refers more people. Oh, I didn't have to wait for my teeth. I just, my doctor came in, took the tooth out, put the implant in. I had very little pain. Why did I have very little pain? Because you didn't raise a flap. And then obviously it's a good practice builder. And it is the most profitable implant when you can do a single stage. Predictable and profitability equals fun. Again, not a niche implant. This was a surprising bread and butter implant in my practice. Okay, so that's the basic cases. In addition to going to Austria, Switzerland, I also went to Austria. I went to the Alps in Austria for a period of time. I'm a bit of a mountain guy. I love the mountains. We're pretty close here. I'm pretty close to the top. There isn't that much different. There's a whole long way down. That's the cabin where I was staying. Very charming, kind of old world cabin. And this is cloud level. I'm at cloud level here in the Austrian Alps. It was pretty awesome. So, all right, let's look at some moderate cases now. So we're approaching the anterior. We're in a lateral situation. The patient has really bad decay right under the gingiva. Doesn't want to do crown lengthening and root canal and post and core and crown, etc. Wants to remove the tooth and have an implant. Before we remove the tooth, we're going to take a simple triple tray, silicone triple tray impression. We do our atraumatic extraction. What is this? The obfuscate, right? So I have a free hand. The obfuscate is pushing the tissue out of the way. And as I mentioned, it's all about the countersink. You place the countersink. If that gray line is in line with the papilla here, roughly, you're good. If that gray line, when I just gently, when I put it in the osteum, if it's up here, no, I'm going to get stability with the CEJ here. That's not what we want. So when I see this, I'm like, that's great. We're good. So I place the implant. This is where the implant achieved torque, but you can't stop here, right? Because of course, this is it has a CEJ. You saw the anatomy has a CEJ. So right now, the facial is facing distal, but it's very minor, just a slight little torque, right? Now you can see slight little torque this way. Now the facial is facing the facial, and I have occlusal clearance here. I check to see how much bone, I just place a thin instrument, how much void do I have palatal, how much void do I have facial, and then I can just fill those in with allograft. This is the tooth that we made him, because remember we took that impression before we took the tooth out. So he leaves the surgery like this. This is, and you can just tell your patients, Mrs. Jones, you can brag a little bit, the teeth in an hour. We just gave you teeth in an hour. You can just say that. You can say, look, this is what we've done for you. Go tell your friends about it. Now the key is, this is a suck down temporary. This is not cemented. Okay, do you follow me? We took a mold, fill it with acrylic, place it over the tooth, clean up a little bit of the flash, but we leave this in the mouth long enough so that the acrylic shrinks around the abutment. That's how it stays in. That's all the retention you need. It's just a shrink wrap temporary. There's no cement. This is an immediate extraction site, so why mess around with cement? So there's no cement here. It's just suck down acrylic. This is the day of surgery over the implant. This is a week later. Looks better a week later. Has got some stain on it, so he matches now all of his other teeth. I always, when I took these, started to, work with Ceraroot, I couldn't believe the tissue reaction, right? Only a week after surgery, I couldn't believe it. So I started leaving the sutures in and taking the pictures with the sutures in, just in case somebody said, well, that's not right. This isn't a week later. It is. These are all a week later. This is 4 months later. Tissue is healed real nicely. So let me turn it over to you guys. How do you want to restore this? Well, I think that's probably a little bit too much for cord, right? So just take a little diode, expose your margin here. Remember I said a distinct advantage between this and a flat system. It already has a CEJ. You don't need to go and trim all this, facial. If you had I'm not picking on Z systems. It could be any implant. If you had an implant that was that the shoulder was one level, of course you have to create now a sculpture. You have to create a shoulder, drill all that away. That's time, right? That's trauma on the implant. That's time. All I want to do is I just want to take a little bit of diode, remove this, just tuck this back a little bit so that's not showing. And there's the final Emax. Here's another case where this lady here had previous Ceraroot implants, so she's a believer. She doesn't want more, but she's happy to get more when she needs it. These back molars here are in real big trouble. They're pretty severely infected. She's having some breast health concerns, and she was concerned about these teeth being on the meridians, And so I'm not a traditional Chinese medical doctor. I'm not here to diagnose her with anything. I just see bad, infected root canal teeth. She doesn't want retreats. She doesn't want anything to do with that. She just wants them out. So we're able to extract the teeth, and you can see after we extract these teeth, there's so much infection, right? Of course, we clean out all of the infection. When we clean out all that infection, they're just big holes here. I don't show you the countersink picture, but if I did, the countersink would go right in. Can't do immediate here. So what do we do there? We do our socket preservation. Again, this is a PRF membrane. Same thing on the other side. 4 months later, everything's healed up really nicely. I've already placed my palatal, I've done my freezing, got my Optrogate in. And again, if I've done the socket preservation, I know there's plenty of bone. I usually do these flapless. And so here is immediately following placement of these 3 implants. We did them flapless. You can see the blanching of the tissue because, well, the tissue wasn't used to having an 8.5 millimeter implant in there. So that will adjust, work itself out. Prosthetically, as I'm placing them, I'm thinking prosthetics. There's this TEJ in line with the CEJ of the other teeth. I got my occlusal clearance here. There is no problem here. You have solid, these are solid implants, right? What I do is, of course, I scare all my patients, whether it's an immediate or not. I say, look, don't chew on this, don't even touch it, don't push it, don't use your tongue on it. I try to scare them. There is something to be scared of. If you do crazy things to your implant during the healing period, titanium or otherwise, you loosen it. But if you advise your patients properly and you sort of say, you scare them a little bit, they're generally very, very good. This is the other side. Here's a CEJ, pretty much in line with the other CEJ. Is that enough occlusal clearance? On the day when I go to, impress these, how hard a time is that going to be? Does anybody have a problem with taking an impression of that? Right? It'd be very easy. I want to leave my margins. Remember I said I play a little game with myself. The game I play with myself is, I think, okay, when I go to restore these, how easy can I make it for myself so that I can just, have an easy impression. So that's all. There was the day of surgery. And there are the restored crowns there. Again, full-size crowns over a full-size implant. Here's another case where this gentleman comes in and I see, he's got bombed out bad, broken down molars here and here. These are all patched together with composite and mercury composite. Just, his back teeth are in really bad shape. This isn't a dietary problem, right? This isn't a nutritional deficiency, other than, yes, you can say he's got a narrowed arch. When he was young, he had maybe airway problems and Weston Price, of course. But essentially, I'm not going to go down the road with him and say, how can we improve your diet to improve your teeth here? This is a structural problem. So what do you do with cases like this? I love cases like this because when there's these molars, right, I use the mesial molar here for my osteotomy. This is where my implant's going to go, right down this line. The implant's plenty big, so I'm going to engage this wall. I'm going to engage some of this wall. I'm going to get great stability. Here, same thing. I'm going to put it in the mesial root. When I'm looking down when I'm looking down this osteotomy, I'm not even thinking here. I'm just going boom. I'm going for that mesial root. I'm going for that mesial root. I'm going to have great distance from here to here. I'm going to have great distance between implants. And I'm going to, once I do both my osteotomies, I'm going to fill in with my allograft these big distal roots. Then I'm going to place my implant. So again, I'm checking with the countersink. This needs to be down here. So guess what? I needed more preparation. If I didn't do enough preparation, my implant would stall out halfway through. I'd be like, oh, darn it. So then I just take it out, put it back into its vial, prep some more, check it with my countersink. Is this gray line here? Yes? Good. I'm done prepping. The back one is pretty good. Maybe needs a little bit more prep. These are the 2 implants placed. Again, These are placed in the mesial root here, the mesial root here. Distal root is packed already with allograft, putting it in line with all the where it needs to be. Remember I said that we're going to preserve the most amount of hard and soft tissue with this implant? You guys remember that from the first lecture, right? Why are you going to preserve the most amount of soft and hard tissue? It's because you're placing a big implant at a time when the patient has the most amount of soft and hard tissue, and you're going to fill in the voids with allograft. So here we are suturing up. Again, I would not have left this here. I would have just taken half a millimeter off of this, so I didn't have any primary occlusion during the healing phase. And again, Dr. Fields yesterday was saying that in the posterior mandible, on a case where there's compromise of bite, he doesn't want to do any of these implants in the posterior, right? I respect his judgment. He's got 100 years of experience more than I do, but I can tell him or you or anybody that with Ceraroot, with these strong big implants, you get primary stability in the posterior on somebody who's destroying his posterior teeth. You don't have those problems. You're not. If I was having problems, if I was having a lot of failures, a lot by 10, 15, 20, et cetera, I do these. If an implant comes loose, and I don't think the patient did something crazy, I redo it at no cost to them. Why can I do that? Because there's inherent profitability built in. It's never an issue, and it happens so little. If it was happening a lot, if I was having a lot of problems, it would be impossible for me to continue doing strictly zirconia implants and strictly immediate implants all the time. It would be impossible, but it's not possible. It's not impossible. It is possible because it works. The success is there. And as I shared with you in the first lecture, it's not because, I've drank some implant Kool-Aid and made me super implant guy that you haven't. It's not that. You can do this too. So this is the closed up site here. Here's the x-ray. Again, you can see we're into the mesial root here. The distal root has been filled with allograft. This is the distal root of that other one. This implant's been in the mesial root. I overcompensated a little bit. I know the teeth were tipped. I wanted to place these straight with ears. I overcompensated a little bit. Not a problem. Here's a week later. I'll leave the stitches in. This is his dealing with the, now I'm a holistic dentist. I'm dealing with not only why he came here, why he broke, why he, replacing his missing teeth, but also ensuring he doesn't break other teeth. This is orthotic to find his bite. And, how do you do that? How do you go from a patient that comes to see you for a broken tooth that needs an implant to helping them understand their underlying problem, helping them, sign up to fix their underlying problem? You can't do that with a CE course, right? That's where mentorship comes in. Whether it's me or somebody else, look for a mentor who can help you if that's what you want to do. If you really want, it depends on what you want to do. But if you want to get to the stage where you're able to help your patients that much more, I helped him by taking out those bad teeth and giving him implants. This is the case I showed you before, which was not completed. I completed it later. But now I've helped him even more by finding him a proper, comfortable bite. So now he's not going to break those teeth. This is again in the Austrian Alps. I mentioned I love the Alps. This is one of the highlights of my trip here, where not because I got to look at the rear end of a cow, but because I was up so high, up in the Alps here. You can see it's a long way down, and I had a chance to where I was staying at this very, very humble kind of place. I just asked the guys, I said, hey, can I come help you herd these cows? And they looked at me like, okay, who's this guy? But anyways, it was a thrill for me. I got to go chasing these up the mountains, 45 degrees. It started raining. There was manure everywhere. It was fantastic. I was up in the Alps. I couldn't believe my eyes. It was truly a trip, truly a highlight of one of my highlights of my trip. All right, so let's look at some advanced cases now. And again, I thought that zirconia really was for the anterior only. Remember, when I thought I was going to take this training, I thought, well, I'll use this 1 out of 10 times when there's a really aesthetically conscientious case, and I'll use zirconia for this. I thought it was a niche implant. I thought it was only good for those aesthetically tough cases. And it is. I'm going to show you all these advanced cases now. These are the tough cases. But I already showed you many cases, and I had to cut 100 slides out of all the bread and butter cases. That's time simply doesn't allow. But that's where the beauty of the system is in the bread and butter. But it's also used for the anterior. When you do anterior cases, there's more risk involved, right? It's still advanced surgery and advanced prosthetically. More risk means less profit. You will do cases more often. You will redo a crown more often, right? Because it has to be just perfect. So more risk is less profit. Don't be like me. Don't start with these cases. I did, and I'm here to tell you, you should, try not to do that. So let's look at some advanced cases, right? This is what we all thought zirconia was really about. Is a young lady, she's getting married, didn't like this root canal treated tooth, didn't want anything to do with retreats, wanted the tooth removed. Here's the PA. So atraumatic extraction. Again, you can see the Optergate in here. So I'm placing the same thing, right? You're seeing the pattern. You place your countersink in here. What do you think? Too deep. If I place it here, that CEJ is going to end up getting stability way up here. And I'm going to be digging after it and causing myself problems. So guess what? Remember, there's two central incisor widths. There's a bigger one for bigger sockets. Great. It's this one. What do you think about this? Is it a go? Yes, that's a go. So we place this. You saw this picture before. Place the implant. The abutment is slightly facial than I need it to be. I can trim that back when it comes time to do the prosthetics. Here's the occlusal clearance. And here's the end of the surgery. Sutures are in place here. Again, why do I need to complicate my life? Why do I need the two-stage? Why do I need to cement this abutment in later? Why do I need to screw it in later? The CEJ is all there. This is the post-op x-ray. So let's talk about temporization. We can't talk about the interior without talking about temporization. You must have two options for temporization when you're doing an immediate or you're planning to do an immediate in the anterior. The safest and easiest option is an Essex. Okay? An Essex with a tooth, with a denture tooth in it, right? An Essex with a denture tooth in it. This is the safest option. Why? Because, well, what if you can't place the implant? So, of course, you have to give something to the patient to walk out with. What if you place it, but you don't get ideal stability? You don't want anything touching it. You don't want you can't put any kind of a suck down tooth on it, right? You want nothing to touch it. So you use an Essex. And you also want extra tissue overgrowth over the margins. An Essex will provide that for you because there's nothing on the margins. And the second option you need to have ready is a suck down for tooth. So if everything is ideal, you got great placement, you got great stability. Now you can just give them a tooth in a day, like the example I showed you, right? They walk out with a bad tooth, walk out with a tooth in a day. And of course, don't bite on it, don't chew on it, don't look at it the wrong way. All of those things are in place. And so you need to have two options. So for this lady, we had an Essex ready for her. So that's how she walked out. I don't do, what are they called, flippers. When you're thinking about a one-step or one-stage, one-piece implant, right? Obviously, you can't do flippers anymore, right? There's going to be a problem. You can't do a flipper. And flippers, to me, when you're talking about, again, personal preference, anybody out there who's using flippers and having a great time with them, that's wonderful. For me, because so much of what we're doing is involving some sort of soft tissue or hard tissue grafting in and around the implant, to me, I don't want anything to do with a flipper because, of course, even as careful as they are, even if they don't bite on the tooth, they bite, they're going to cause some pressure, potentially cause some pressure on the tissues. With an Essex, of course, it's tooth supported, right? As long as you've cleared out enough space from the denture tooth to the implant, they're not going to touch your implant. They're not going to touch the soft tissue. That's the key. They're not going to push. If you've grafted the side, if you've done something, whatever, they're not going to touch your soft tissue. So this, to me, an Essex all the way. Essex and suck down, for me, flippers are gone, no more. For once, because of the one-piece implant. 4 months later, this is what we have. Remember, we said that the tissue is, this implant is osseointegrative from the apex right to there. So the tissue and the bone just love the implant all the way. So now I have a very wonderful problem. I have too much tissue. So now I can just sculpt this tissue back the way I need to. How did I do it here? I'm aggressive on the palatal because, well, it's the palatal. No one's going to see it. On the gingiva, I'm far more conservative. I placed a cord here. This was after the impression. This was a lot cleaner. Remember, guys, I'm a two-handed, wet clinical dentist, right? I'm not I'm not into research. I'm not into anything else. I'm as busy as you are in your practices. But so when I'm taking these pictures, I'm trying to think about what I would want to show in a lecture. But some of these will be after the impression or something. And this is the final result here. We had, I'm proud, I guess, that we have in the Ceraroot magazine, there were 2 cases of ours that were published in that magazine. This was one of them. Again, that's not because, I drank some juice that you guys don't have access to. This is a great system that'll make you look great and make you a better dentist. And this is a follow-up x-ray I've taken some time ago, and the bone is very solid. There's our final result. So let's look at some other advanced cases. This is another a lady who's come in with a root canal bridge on both sides, concerned with infection, having pain in the area, doesn't want anything to do with a retreat, etc. This is the pre-op x-ray. You can see that we've got potentially some sinus, potentially there's a root here in the sinus. So atraumatic extraction, no flaps, clean out all the infection, and lo and behold, what do we see? We see a hole, right? We have a perforation here into the sinus. What should we do? We can, if we're comfortable, not comfortable, whatever, we can just socket preserve this. Patient already knows, ma'am, this wasn't the ideal day for an implant today, right? We'll come back, do the surgery in 4 months, no problem. But you don't need to do that. I can show you this. This is basically just allograft around the edges. This is PRF that's been cut, and I'm going to use this as a plug. This is the best biological plug that we can have. It has about 30, different growth factors that will differentiate and grow every kind of tissue, including Schneiderian membrane, bone, gingiva, whatever it needs, it'll differentiate and give us those growth factors. So when I'm placing this as my plug, right, I'm making sure that it goes right where I want it to go. How am I making sure of that? I'm doing it by placing the implant into that plug. So it has no choice but to go to the end of my implant into the perforation. So there's that implant there. And for the premolar, I've placed it, and I'm just releasing the tissues conservatively because I didn't get it up that high, so I want to bring the tissue down a little bit. This is the end of the surgery here. I've given myself enough clearance. Again, I'm just playing a game with myself. I'm thinking, how easy can I make this for myself when I want to restore this? Very easy here. By the way, these are all primary stability cases, right? If I didn't have primary stability, let's say I placed this implant and I didn't get my 30 Newton centimeters, what would I do? I would, if I was close, like 20, 25, whatever, I have a couple of options. Number one, I can take some flowable and bond this to the tooth behind it. I'll just wrap flowable, cure it, make a bridge, wrap it around here. That works. I have 5 cases or so I've had to do that. It works very, very well. It integrates. If it's flopping in the wind, no go. I'm saying if it's just not, if you didn't get 30, if you got 20, 25, if it's flopping in the wind, you have to take it out. That's not going to work. Or you go deeper if you can. But I got stability with experience, etc. So I'll place this implant here. This is a tap in. That's 30. And yeah, so that's it. And then this is the bite wing, or sorry, the PA. You can see some of the bone. This is a week later. Again, I always leave the stitches in. A week later, I mean, that's pretty cool, right? The patient walks in with two bad root canal teeth. You're able to take the teeth out, give her some beautiful ivory back in place, and she comes in like, that's a great service. How do you grow your practice? How do you become successful? By serving your patients or disserving your patients? You grow your practice and become successful by serving your patients. So when you're able to provide this service, right, this is going to lead to success. Everybody's happy. This is 4 months later. Now look, if this was recession, that would have turned this color of all the other teeth, blends in, it's nice. This is just plaque. Remember, this is roughened surface right to the apex, right? It's roughened. So plaque will adhere to this. What do? Just take my diamond, clean it up. And then here's the occlusal view. How do you want to impress this? By the way, I don't use guides for these, but I think the system is just so good. You get parallelism pretty much all the time with bridges. I've done this lots and lots of bridges. You get parallelism pretty much all the time. And if you don't, you just prep it, or if you're like me and you're lazy, you just say, hey, please block out the distal of this and give me relief, and my bridge goes down, right? It's not that, it's easy. But anyways, prep it, clean it up. What do you want to do there? Maybe just a little diode. So do you think you can freeze this, do a little diode, pick a burr, whatever you like, clean up this, and take an impression? How long do you think that'll take you for a bridge impression? Do you think you can do better, preps than this for your bridges? I can't. Unless I spend about 5 hours, right, on it and checking it a million times. But guess what? It's already made for you. And here's the final bridge. Here's the CT afterwards. I think we've got some bone growth up along the sides here and maybe some on the apex. The allograft I was using here was mixture of cortical and cancellous. So because it's a mixture, the cancellous bone doesn't show up very well at all in the CT, so we can't know for sure. Since then, I've switched to pure cortical. If I'm doing a sinus bump, I just use pure cortical allograft so that we can see it on x-rays much better. She's very happy. Here we have another advanced case. Young lady, very conscientious, very aesthetically driven. Here's her dilemma. She has these retained primary teeth here and here, and canines, and then she has her adult canines here. At the time she came to see me, she had already had, I don't know how many ortho consults. She wasn't biting. There's no way. I tried to convince her. I said, look, you got to do ortho. This is a slam dunk, simple case. Get the baby teeth out, push those teeth out, et cetera, et cetera. Nobody could convince her. So believe me, she was going to go to, Mars or Spain or wherever to get implants. She was not going to do any ortho. So I said, okay, you've made your informed decision. You want these out. You get implants. So my question to you is, with which implant system would you feel comfortable doing this as immediates? We can see the roots here. These aren't actually just, these aren't really tiny pedo roots. There's still some meat left to these roots. And, here we have these canines. So, I don't know about you, but there's no other implant system in the world that I would feel comfortable with, where I would not only, first of all, doing immediate on a canine, but secondly, not just removing one, but two teeth in the same socket site, and then placing an implant in that site in an aesthetically conscious. Okay, so here we have the, a week later, healed site. You can see the sutures are still there. And so at that 1 week, I made her suck down. So I made her suck down temps here, suck down temps here. We got good stability. This is 4 months later. It's healed up. Same story, right? How do you want to store this? Well, I just want to be conservative here. This is the facial, just a little bit of diode. So a little bit of diode here on the facial. You can go aggressive on the palatal. I I refined my preps a little bit, not much. I didn't have to create a CEJ. It's already there. Just refine it. On the other side, same thing. Just refine the margin a little bit, lower that a little bit. You can see the clearance was already there. Just shave that down a little bit on the facial so we get good contours. And here's the restored case. The implants in. Now, with which implant system would you feel comfortable doing this as an immediate? For me, nothing else but Ceraroot. Here's the restored site here, restored case, here and here. And again, this case was chosen for the Ceraroot. Turned out really, really well. I want to show you maybe one other advanced case here where breast cancer patient, young lady, she had 5 root canals, made her informed decision, doesn't want any more root canals, any dead foreign things in her body. I respect that decision. These are 2 of them here. We can see that this is quite a tilted root. The root sort of goes like that. This is a tilted tooth here. So here's the pre-op. And, I don't know if this word exists or not, but orthoimplantology. With this system, right, we're able to remove these two teeth, but also correct that angulation and get it at the right, apical coronal height, get the central right distance to the natural tooth, get this to the right distance, and get the 2 implants together at the right distance. This is the power of this system. This is the healing. This is a week later. Why do I need to, have a 2-piece? I don't know why I would need to complicate my life with 2 pieces here. 1 piece here, plenty of clearance. This case is in progress right now. This is how it looked 4 months later after healing. This is what I love to see. She had an Essex, okay? She had Essex throughout this. And now I'm preparing to do the finals on this. And as I showed you the slide earlier, what am I thinking? I'm thinking prosthetic, right? Is this level the same as this level? No, it's not. Obviously, we need more laser here. This level, no. I'm thinking totally prosthetic the whole time, and we're going to get a great result because we're thinking prosthetic, because the implant has a CEJ. There's no micro gap to worry about. Everything is cool. This is her temp. We're letting the tissues heal from this surgery. I'm going to do final impressions later, but you see we've corrected this without ortho and given her an implant at the same time. This is another highlight of my trip. I got to play soccer in the Alps and back. I mean, this looks like it's Photoshopped, right? A soccer field in the Alps, but no, that wasn't Photoshopped. That's actually what it was. I brought my cleats and gear in case there was an emergency game. There was an emergency game. I'm short of time here, but I just want to quickly went through some lessons I learned. This is a case I placed it too deep. The CEJ here is too deep. Like I showed you, it's way up here, right? It's too deep. What do? I use a Ceracrown. I aggressively laser away. I have no choice. And then I place my Ceracrown, and then I do a pickup impression to capture the margin with my Ceracrown. This now becomes the core for the implant, for the crown. In between the 2 appointments, to keep that tissue away, I just put flowable in here to keep the tissue away. Next appointment, flick out the flowable, seat the crown. There's going to be some bleeding. This is about 1.5 years later. The x-ray got lots of bone here. And this is 1.5 years later on the tissues. So I placed it too deep, but I saved myself with the prosthetics of the Ceracrown. Another lesson learned is in the anterior. I never do any more immediate centrals immediately without a CT scan. I took the tooth out. There wasn't buccal bone here. I told the patient, don't worry, we'll do a socket today. But a socket is not enough. If you don't have buccal bone on an central, a socket is not enough. Why is it not enough? You're doing some guided bone regeneration. Look how much we have to add because there's going to be a lot of resorption. So we add so much. In the end, we got the bone that we needed. Why is a socket not enough? Because if you just get a little bit, because of this, right? Because of this nasopalatal canal, we're going to have limited amount to move palatally. We can't cheat. We've got to place it in the right place. So we've got to have tons of bone. Okay, this is the surgical case here. I added some more PRF. This is his temp. How do you win this case? It's prosthetics. The implant's integrated, but this needs help. This needs prosthetic help. The referring dentist didn't have their camera wasn't working. This patient right now is in Iceland mountain biking. I said, send me a picture. He just sent me his picture yesterday. But that's how you solve that problem, is through prosthetics. He needed new veneers there anyways, and that's what he needed. But lesson learned, you need a CT. I've had exactly 0 fractures with Ceraroot. I've placed over 500 of these implants. I've had exactly 0 fractures with them. Of these implants I've placed, I probably have a 5 to 8% failure rate. 95% of those failures have come from inadvertent loading in the first 4 months, and that's my fault. It's my fault because when I made an Essex for the patient, I didn't see it enough to see that I relieved the denture tooth from hitting this. I asked my lab, hollow out the inside, make a veneer. Still, they don't do it enough. I try to remove it, but in a few cases I haven't, and they've been having an Essex that actually did contact the tooth and then it functioned, and then it didn't work for those reasons. Very, very, very few cases. Okay? I'm out of time. Thank you.